Yes.
Yeah, this is Dr. Ramesh, medical and hemato-oncologist, Omega Hospitals, Tirupati. So I have been, I'll be more, taking the session forward. And at the outset, I'd like to thank Bayer and Sandeep for this opportunity. And I would like to introduce the speakers, Dr. Madhav Dantla sir, whom we know very well, Omega Hyderabad. So the next speaker will be Dr. Nitin Raj sir. He's at Calicut. Okay, hi sir. Hope mm, mm, before the further review, yeah, as we know, prostate cancer is like an increasing burden nowadays. Previously, we used to see in older age groups. Now we are seeing in younger age groups, even like 50s and 60s. And as the age progresses, and like in 70s and 80s, they'll be on polypharmacy with multiple cardiovascular drugs, non-communicable disease drugs, and all. So decision making in such a patient population is definitely a challenging thing, and both our speakers will be enlightening us regarding those, and I'm eagerly waiting for it. And without wasting much time, I'd like Dr. Nitin Raj sir to uh, start the session. His topic is on reaching new heights in metastatic hormone-sensitive prostate cancer, care and case presentation, with practical considerations in the management of metastatic hormone-sensitive prostate cancer. Over to you, sir.
Yeah, hi. Yeah, good morning. Thank you for the opportunity. I think my slides are visible, right?
Yes, sir. It is visible, sir.
Okay. So basically, so we are actually like previously what we used to think was like, you save the previous concept that is around before 3, 4 years. Like the concept was, save so many drugs for the later, the further down the line. You have to use first docetaxel and then abiraterone, then cabazitaxel, then enza. So always saving something for the future was the standard of care. Now the entire concept has actually changed. Now it's like go hard in the first go and get the maximum PFS, delay the further systemic therapy. So here actually there is a huge shift in the management of metastatic hormone sensitive prostate cancer. So I'll just brief regarding the current scenario in the management of metastatic hormone sensitive prostate cancer. So the slides basically it's by the company, and again, like at present in India, there are approvals of second generation androgen receptor inhibitors. The darolutamide is approved for non-metastatic CRPC patient and metastatic HSPC in combination with docetaxel. There is a triplet therapy, and darolutamide is indicated as a single treatment for the metastatic hormone prostate sensitive prostate cancer also. So here we can actually see the prostate cancer landscape. So the prostate cancer landscape actually starts, it can either start from a localized or locally advanced prostate cancer, which actually has a biochemical recurrence, and there might be, it might be a non-metastatic CSPC, CRPC, or it might be a primary progressive metastatic hormone sensitive prostate cancer, or in many of the clinical cases which we get, we might actually deal with a non newly diagnosed, that is de novo metastatic hormone sensitive prostate cancer. And later on, it progresses to metastatic CRPC, and then finally the terminal disease and death. Patients who actually suffer and die of prostate cancer has everybody will have a metastatic CRPC. Just today, I lost a patient. So yeah, the treatment of metastatic CRPC, the overall survival improvement is only by about 2.5 to 4.5 months. That is, if you actually go for intensification of the treatment, when the cancer is actually metastatic CRPC, there is only an overall survival improvement of around 2.5 to 4.5 months. So there lies the entire problem. So instead of focusing on how to improve the metastatic CRPC survival, it is better to actually prevent the disease from reaching metastatic CRPC. So yeah. So the So previously what we used to do was there was only ADT, which was the standard of care for a long time. So ADT actually you can have LHRH agonist or antagonist, or it can be an orchidectomy. So a surgical castration or a medical castration. So that was the standard of care. Then came bicalutamide, and then came the landmark trial, which is the STAMPEDE arm, where actually it was shown that addition of so this began the intensification era in the metastatic HSPC. So here actually the STAMPEDE had many arms. So I think it was up to arm H, and it was actually the beginning of the docetaxel era in metastatic hormone sensitive metastatic prostate cancer, to be real. So here there was actually a improvement in the failure-free survival and in the overall survival. So this was just the first stepping stone. So now we have climbed up from here. So if we go through the STAMPEDE, so there is another question. So there was a clear-cut benefit regarding intensification from the ADT. That is the best takeaway I would from the STAMPEDE trial. So, you intensify your ADT with something else. Either it could be a docetaxel, it could be abiraterone, it could be RT. So everything was actually better. I think the only negative ones was this ZA and I think celecoxib or something of that sort. Only those were the arms which did not show any benefit. And the introduction of the prostatic RT, that is a local therapy for the metastatic HSPC. So the STAMPEDE trial again established two categories, that is based on the volume. So the less than 4 bone metastasis was categorized into low volume disease, and there was a clear-cut overall survival and the DFS benefit with the introduction of local radiotherapy in a metastatic setting. But for the high volume metastasis, there was no much benefit regarding the prostatic RT. So again, so after that was, I think, in 2016. So there was J2 trial, which was actually, again, that began actually the docetaxel era. Then there was STAMPEDE, where the hazards ratio, if you look at everything, the hazards ratio has been keeping on improving and it is very steady. So even if you look at the confidence intervals, they are also very tight. So intensification was mandatory, not just ADT, because previously even the urologists used to just give ADT and put the patient on bicalutamide. So we moved on to the second generation ARPIs. So STAMPEDE trial actually, the HR hazards ratio was around 0.81. Again, Latitude came with abiraterone, Arches came, 0.66 HR was there, then Titan, then Enzamet. So these are all the doublet. Then in 2021, we moved on to the PEACE-1 trial, where actually there was a protocol was amended, and actually it was proven that triplet therapy can actually improve the overall survival. So here we are looking only at the overall survival. So prostate cancer is a very prolonged illness. It is very slow growing. So there was still an overall survival benefit. So then came Avastin's trial, which had one of the best hazards ratios, that is of 0.68, which was in 2022. So here we have a plethora of options to choose from. So what does the best treatment option is what we will be looking through this presentation. So in Charter trial, there was actually docetaxel was the main comparator. So it was compared high volume versus low volume. So there was a clear-cut benefit in the high volume, but in the low volume, in fact, the HR was hazard ratio was around 1.04. So there was no improvement in the overall survival. But in high volume, there was a very clear-cut improvement of around 16.8 months. That is, we are gaining more than close to 1.5 years extra survival for a metastatic prostate cancer. So this was a huge achievement. It was one of the biggest achievements that we have seen, that the benefit was really big. And then came Latitude trial. So in Latitude trial, so the entire follow-up was around 51.8 months, and we can actually see that the Kaplan-Meier survival curves are actually separating early on, and the benefit was very well sustained. So abiraterone was the first to show that hormonal treatment can also be effective. So, with the Stampede, we had already told that chemotherapy is essential in metastatic prostate cancer, especially in higher risk. But abiraterone was the first hormonal agent which actually improved survival. So, whenever the patient was not fit for a docetaxel, we could definitely put the patient on abiraterone. So, it gave us a second option. So again, when the toxicities of abiraterone, mainly the prednisolone related, there was hypertension, there was mild hepatotoxicity. I think hypertension, the diabetes, the hypokalemia, and the fluid retentions are the ones which we generally deal with. So yeah, but again, this was kind of acceptable. So again, then we had our next option, which was apalutamide. So apalutamide actually showed a good PFS benefit of around 0.48, and there was a good overall survival of 0.65. So here the apalutamide plus ADT was only compared with ADT. So it was not, I'm not very sure by that time whether the docetaxel was mandatory, but the benefit was actually sustained both in high volume and in low volume disease. So again, next came Enzamet, where we actually compared enzalutamide plus ADT versus non-steroidal anti-androgen plus ADT, Bical or something of that sort. And again, there was a very clear-cut progression-free survival and overall survival. So again, the benefit was mainly in the low volume. Higher volume, the numerical advantage was there, but not very much statistically significant. So again, then we started thinking, why not combine therapies so that the patient becomes more castration sensitive for a longer time? Because we know that, the castration sensitive, the tumor biology is different, the causation is different, there is anti-androgen response. But when the patient actually starts becoming castration resistant, so there comes the newer mutations and everything, which might actually deem the patient more refractory to further therapies. So there was a decline in survival in that. So why not intensify the upfront treatment for a metastatic prostate cancer? So there lies the thought of that began the PEACE trial, PEACE 1 study. So mainly it actually includes the de novo metastatic disease, and it actually had a high volume and low volume stratification, and the performance status was also quite good in this study. So here also, when we actually look at the trial design, they have only included the people who can actually tolerate the treatment. PS2 and PS3 were not included. So the randomization, basically it was a four-arm study, 2 by 2 trial design. And initially the standard of care plus standard of care versus standard of care plus RT, and standard of care plus abiraterone plus prednisolone, and addition of radiation to the same. So the standard of care in PEACE 1 after the publication of the Stampede was changed to include docetaxel, and majority of the patients eventually actually started to receive docetaxel. Thereby, there was a dilution regarding what the intent of the trial was. So was it just the abiraterone versus docetaxel was addressed? That was a little diluted after the protocol was amended. But this actually paved way to further insights on how to improve the overall survival. So there was a clear-cut uh, benefit in the higher volume disease and in the low volume disease, with the hazard, the over median survival was around 5.1 years versus 3.5 years. So there was a very clear distinction. So again, if you look at the survival curves, the curves were not separating initially till the more than 1 year mark. It was not separating. And when you look at the lower volume disease, actually we can see, even though the hazard ratio is 0.83, it was not statistically significant, and the curves are frequently crossing each other. So the lower volume disease did not seem to be beneficial as the high volume disease. So we thought, okay, chalo, a high volume disease might actually, they are the only ones who actually derive benefit from the triplet therapy and not the low volume disease. Then came ARASENS trial, which was actually a global randomized double-blind. So other one was open label. This was actually a double-blind, placebo-controlled phase 3 trial. And it was the main inclusion criteria was metastatic HSPC. ECOG was actually good. Candidates for ADT and docetaxel was there. So again, docetaxel plus darolutamide versus docetaxel alone. So they had lots of secondary endpoints, but the primary endpoint remained the overall survival. So and the secondary endpoints were time to castration-resistant prostate cancer and time to pain progression, symptomatic skeletal event-free survival, and subsequent the time to initiation of subsequent antineoplastic therapy for physical symptoms. So they included different aspects: the safety, the tolerance, the quality of life, everything. There was one secondary endpoint which was actually included in the trial design. So the adverse events between the arms were almost identical, and 87% of the patients received all of the 6 cycles of docetaxel, thereby deeming that, if you choose the right patients, they will actually tolerate this regimen very beautifully. So here actually we can see that survival curves are actually separating early on, and they are maintaining in that way, and the censoring has been done, and the confidence interval is also very tight, and the hazard ratio is around 0.68, which actually is a very good benefit. So the overall survival was definitely there. But the main thing came, high risk, we already have seen in the piece one, there was a benefit, but even in the lower risk patients, so there was the first time that there was actually a clear survival benefit with the triplet therapy. But even though the confidence interval was a little wider, but again, we can see the curve separating very early on, and it is not crossing, and the benefits are actually sustained for a prolonged interval. So the benefit in ARASENS are both in the high volume and low volume disease. And there, if you look at almost all the endpoints, so time to CRPC, the time to first antineoplastic subsequent therapy, time to pain progression, time to first skeletal event, everything, there was actually a risk reduction, where time to CRPC and time to subsequent antineoplastic therapy, more than 60% reduction was there. Thereby, this is a big success. So again, we are not looking at the time to PSA progression was also very clear cut. So more than 2/3 of patients actually reached below 0.2 in overall study. So if at all, the benefit is, you have got even an adverse event or something, you can even take a break. That will be explored in further trials. But again, the nadir has gone to less than 0.2 in more than 2/3 of the patients. So overall survival again that benefited. So yeah, just skip. Yeah, so the PSA response was actually quite good. So the undetectable, that if you look at the numbers, the darolutamide with the arm actually had at any time around 83.8% achieving undetectable PSA levels. Actually, in many cases, like we can actually de-escalate the therapy even with this. So definitely there is a very clear-cut benefit. And again, the next question would be, when would you actually choose a doublet, or when would you choose a triplet? So here in our clinical practice, what we generally do is we actually first look at the general condition and the affordability. So if the patients are able to tolerate and accepts docetaxel, so like some people tell, we don't want chemotherapy, there need not be hair loss might not be acceptable. So taking all these things into consideration, if they are willing to take docetaxel and they're able to tolerate, there is a performance status and age. Age exactly is not a cutoff, but definitely we should look at the frailty of the patient. You can actually look at the geriatric score and everything, and you can actually deem whether the patient is fit for chemotherapy. If they are fit, I would consider a triplet therapy. Then again, the high volume or risk, definitely I would want to intensify the treatment. And again, the life expectancy. So if the life expectancy is very high, then I would definitely want to hit hard and early. Because eventually, once the CRPC develops, the quality of life might actually deteriorate. And will the docetaxel be an obligation in the near future? Then that is definitely that is okay. The patient needs to be informed very clearly regarding the options, the benefits, and the risks which they take. So, and again, one more thing would be whether the toxicities also, I would want to keep that also in mind regarding whether the triplet therapy, whether they, again, that again comes in the frailty. So in the present era, we would definitely we should be considering a triplet therapy, especially in high volume disease. And if you're considering the darolutamide and the patient is willing and they are affording, definitely I would suggest getting a triplet even in a low volume disease in metastatic hormone sensitive prostate cancer. Yeah, I think that is the slides. Thank you.
Yeah, thank you, Dr. Nitin. That was a nice presentation and a nice journey through regarding how things used to change every 2 years during our residency and post-residency. Yes, actually, the older teaching used to be like no one will die of prostate cancer, they will die with prostate cancer. But as the age of presentation is reducing and as the life expectancy is increasing, hitting hard will be a better option rather than waiting to go to CRPC and succumb to it. Yeah. Now, I would like to invite Dr. Madhav, sir. His topic is on advancing metastatic hormone-sensitive prostate cancer treatment in the horizon, darolutamide without chemotherapy, the ARANOUT evidence. Over to you, sir.
Do I have to share my slides or are you going to display them?
Sir, can you please share the slides if you are
Okay.
comfortable?
Fine. Are you able to see my slides?
Yes, sir. We can see the slides and you're audible. Please go ahead.
Okay, fine. So that was a wonderful talk, and it has made my job much easier because a good assessment of how we got here, and also all the trials have been discussed, and also when we choose doublet versus triplet, that has been discussed as well. So my job for today is taking you through the evidence of the ARANOUT trial that basically looked at darolutamide without chemotherapy. And this was on the back of, one second, I'm not able to, yeah. So this was on the back of the ARASENS trial that looked at Daro plus Dosi in combination with ADT. So I'm not going to spend too much time on this slide because we've already gone through the journey of how we started with ADT alone, and then the concept was that you would focus on sequential therapy and add any of these drugs at progression. And we then later on moved to doublets. And now we have good data with the triplets as well. So the reason why we are giving combination therapy is that we want to get to a point where we are avoiding deaths from the castrate resistant prostate cancer. So the unmet therapeutic need is that apart from the outcome data, you're also looking at an improved safety profile, and Daro does fit the bill in terms of reduction in significant toxicities that are seen with the other agents that are approved in this setting. So the background is that in the ARASENS, darolutamide plus ADT plus docetaxel did demonstrate a favorable efficacy and safety versus ADT plus dosi. And the ARANOUT was designed to provide a new treatment option, especially for those who are not too willing for chemotherapy, specifically docetaxel. So this was the study design. Metastatic HSPC patients, ECOG PS 0 to 2, and stratified by presence of visceral metastasis and also prior local therapies in a 2:1 randomization to either darolutamide plus ADT compared with placebo plus ADT. The primary endpoint that was looked at was radiological progression-free survival. The secondary endpoints were overall survival and a whole bunch of other secondary endpoints like time to initiation of subsequent therapies, time to progression to CRPC, time to PSA progression, the rates of undetectable PSA, and also the time to pain progression, and also safety, along with some quality of life scores as well. Uh, and 100% crossover to darolutamide was allowed at progression. This slide depicts that there was a very good representation of Asian patients, unlike most other trials that focused on Western populations. And there was also a good representation of patients with de novo MSHSPC. High volume disease occupied 70% of patients on both arms. And this kind of reflected how most patients present in the Asian setting as well. So very reflective of our populations, where a lot of them do present with de novo metastatic disease and high volume disease. The same is represented in this countrywide representation in trials. Roughly around 14% of patients on the trial were from India. So if you look at the outcomes, Daro plus ADT did significantly reduce the risk of radiological PFS by around 46% compared with the control arm, and the hazard ratio was 0.54%, 0.54. Again, early separation of curves, and this continued throughout the trial follow-up period, which was around 25 months. And at the end of 25 months, the median, the RPFS hadn't been reached on the Daro plus ADT arm compared to the placebo arm on the trial. And this slide basically depicts that the benefit was consistent across subgroups, including patients with both high and low volume disease. Again, if you look at the secondary endpoints, which I will stress on the later slides, all of the other secondary endpoints like time to progression to metastatic CRPC or PSA progression or need for subsequent therapies, all of these were met. The one secondary endpoint, again, the OS data was immature and patients will be followed up for survival. But one of the explanations was that almost 100% of patients were allowed crossover to darolutamide, and that might have influenced why we do not see an OS benefit yet with this data. The other criticisms were that in the trial, the comparator arm was ADT alone as against the combination. But then again, if you look at real world utility of combination therapies, one of the difficulties for medical oncologists is we often have urologists treating these patients, and they almost always just put them on ADT and then we have to see them at progression. So in a way, it reflects our real world practice more than most other trials do. Now, coming to the secondary endpoints, if we look at them, there was one interesting thing, that there was a delay in time to pain progression, and this could be of very high importance to patients. Something that has not been demonstrated with other AR inhibitors, but there was no real logical explanation as to why darolutamide did see a delay in time to pain progression and the other AR inhibitors have not. So, but this is something that was reported in the trial. PSA less than 0.2 at any time during treatment, and also time to PSA progression. Around 63% of patients on the Daro arm did have deep responses, and also delayed PSA progression. Higher proportion of patients with undetectable PSA with darolutamide in both high volume and low volume subgroups. And also the need for subsequent anti-cancer therapies was lesser on the Daro combination arm. Again, adverse events leading to permanent discontinuation of Daro compared to the arm was lower at 6.1%. So it did indicate that the safety of darolutamide was preserved independent of the PSA response. Fatigue was one of the most common adverse events in the darolutamide arm. Compared with, something that we do expect but nothing too significant. So if you look at the quality of life scores, again, it did extend the median time to deterioration in the FACT-P total scores by 5 months versus placebo. And it is the first and only AR inhibitor to have demonstrated clinically meaningful delays in pain progression, like I had mentioned in the previous slide, and also a sense of overall well-being, which was significant in this trial. Uh, they did look at social or family well-being, functional well-being, and urinary symptoms. All of these are very important to patients with prostate cancer, and darolutamide combination did demonstrate improvement in social, functional, and well-being. So what are the conclusions of this trial? Now we already have data on the triplets from both the PEACE-1 and the ARASENS trial, and this trial did conclude that combination of darolutamide plus ADT without chemotherapy significantly improved the radiological progression-free survival in metastatic HSPC, and the benefit was seen across all the secondary endpoints in terms of the reduction in PSA or the time to subsequent therapies. Also, response was uh, also associated with a reduction in pain progression and improvements in overall well-being. And it now places Daro plus ADT without docetaxel as an additional option in metastatic HSPC. And like Dr. Nitin had explained, that it is up to the shared decision making to tell the patient that you now have the option of not receiving chemotherapy in this setting, but then the decisions have to be made based on life expectancy, preference for chemotherapy, volume of disease, and also whether it is de novo disease or recurrence, and also whether it is high volume and low volume disease. So it's definitely added another good treatment option. The other advantage of darolutamide is that there are very few drug interactions with darolutamide, lesser CNS toxicity, and it does make the case for improved efficacy at lower toxicities. So I would like to thank Bayer for the opportunity to present, and thank you.
Yeah, thank you, sir. That was a very well explained dissection of the trial, Aranaud, and the real case scenarios. Yes, there's a lot of difference in the trial situations as well as real world, where they even in the non-metastatic setup, urologists, they cut off their, they do their archirectomies and keep them on Bical, and later when they progress, they do come to us. Yes.
Also,
Now, yes.
it's like these tumor boards, the urologists have one case of prostate almost every tumor board, and they're learning from us, right? They've started doing combinations of chemotherapy drugs as well. So yes, we are
Good
lucky
that they are
these
learning.
patients are up front. Yeah.
Good that they are learning, sir. At least some areas they are still practicing the same. Yeah. So now both of you gentlemen has made my work easy regarding the case presentation, especially my cases who are on darolutamide, why I have to choose them. Like, should I like? So, technical team, can you help me in sharing my screen? Hope I am visible.
Sir, you're visible, sir, but
My
I
PPT.
think they can't help you because yeah, now we can see the screen, sir. Yes.
So yeah, during our residency and all, or during the course, we initially had ADT alone. After that, when things started off with androgen receptor blockers, first generation especially. There we had some or little success, then followed by abiraterone, docetaxel introduction, the sequence which Dr. Nitin has shown. So choosing a drug, especially in the non-metastatic setup and the metastatic CSPC setup, was a real life challenge. After that, the second generation androgen receptor pathway inhibitors, androgen receptor blockers, second generation drugs, they came to the front line. And choosing among these secondary androgen deprivation therapy or additional androgen deprivation therapy was a difficult task. So this was one of my patient. So who was a 60-year-old male who was asthmatic, who had on and off usage of steroids. That was mostly from quacks, and later he was an uncontrolled diabetes. So he was diagnosed with stage 4 prostate cancer with PSA level of more than 150 and bone metastasis. He was advised, he was given different options of ADT, and he chose archiectomy. This was the initial presentation where he had non-regional lymph nodes, lymph nodal disease, as well as limited bone metastasis. So we post archiectomy, we started him on darolutamide mainly because of his osteoporosis. We were not willing to start him on abiraterone. So among the second choice, darolutamide was has less interaction, and when we gave the options, he was okay with the darolutamide, and PSA after 3 months have come down to less than 10, and the latest PSA we during the last visit was it was negligible, and later after that we discussed it in the tumor board, and we categorized as very good response with low volume disease, and is a young man, and we added prostate only RT along with darolutamide continuation. And in post 3 months post RT, we did a PSMA PET again, which showed complete response. Now he is disease free within a year of his treatment, and he's happily continuing on darolutamide. The second case scenario, elderly man with who is an epileptic on treatment, and he's again diabetic, as well as he has osteoporotic issues with low backache. So he was also diagnosed with stage 4 disease with bone mets and non-regional lymph nodes. He underwent bilateral archiectomy, and as we know, androgen deprivation therapy alone can progress the osteoporosis. So we discussed options, and we were left with the abiraterone plus prednisolone and enzalutamide, as it has epilepsy risk. So the two other options left were apalutamide and darolutamide. He was CAD also on multiple polypharmacy, though all the second generation androgen receptor blockers, they do possess some sort of cardiac-ish risk, but darolutamide appears to be less interactive with those drugs. That is one plus point, and he was well controlled with the medication. So we gave him darolutamide, and he was having very good control after 3 months. This is the present PSMA PET scan, and there was very good response to him. And later, after 3 more months, we did a PET again. So it was a deep response, but he was not willing for RT, and we are just continuing him on darolutamide. So without the addition of triplet therapy, we were able to achieve very good response with minimal interaction with their day-to-day life based on their medication, their comorbidities, age, and other preclusions, which will be inhibiting for us to add some sort of steroid or other drug. So now after this, I would like to share, I would like to go ahead with the next session, question and answer session. Hope my team is there, Dr. Nitin and Dr. Madhav. So though we have discussed all these things, I would like to have your final word so that we'll conclude this session. So Dr. Nitin, so what would you consider while deciding between a doublet and a triplet? What factors would guide your choice between ARA doublet versus triplet for metastatic hormone sensitive prostate cancer in your day-to-day practice?
First and foremost is the fitness of the patient. So whether they are elderly, they are frail, like whether they can actually tolerate docetaxel. So yeah, that is definitely a consideration. Second thing was whether it is a high volume or a low volume disease. If it's a higher volume, I would definitely insist on this. So these two are the primary considerations. Then choosing what is the best option in among the triplet. Again, the cost is definitely one of the hindrances, but otherwise these two. So what I've seen clinically is like, in the end, I've had patients who are like, 80 years and they have landed up with, metastatic castration-resistant prostate cancer with so many symptoms. So right now, I've got a patient who actually has a penile metastasis, severe pain. So in the end, I am using docetaxel in these patients, even though I'm following the 2 weekly protocol, the 50 milligram per meter square protocol. But I'm forced to use even in 80 years. So why not go hard, go hit up
Upfront
front?
setup. Yes.
Yeah.
Right. Rightly said. Yeah, it's life expectancy is one thing, volume of the disease, and definitely early introduction of all the armamentarium to prolong the progression-free survival is more important to improve the quality of life. Well, then, Dr. Madhav sir, so how important is the combination of delaying the progression and improving the quality of life? Will that play a major role in your choosing the doublet or triplet or additional treatment of 2-ADT?
So, quality of life is definitely one of the criteria that you have to consider. But I think, as Dr. Nitin had mentioned, if I were to choose between the quality of life and also the risk of progression, I would definitely give preference to deciding based on the volume of disease and also whether it's de novo and also depending on the life expectancy. Those 3 points and quality of life again is a factor that has to be considered. But if you would, it's not something that occupies the top spot for me. The other three. Now, if you look at the incremental benefit of the triplet over the doublet, I would say it's roughly around 10 to 15%. And this doublet definitely did demonstrate that it's quite an effective regimen even in the absence of chemotherapy. So it does make a strong case for a doublet. And although it did mention that it had a good inclusion of high and low volume disease, there's no cross trial. I mean, there's no comparison between doublet and triplet. So with whatever available data that we would have, efficacy would definitely take precedence over quality of life. Now, you always have the option of starting off with the triplet, and if your patient does not respond, you can always drop the docetaxel later on in the real world scenario if at all they're not tolerating it as expected.
Yeah, that would answer the third question also. Darrow doublet, that is the game changer when compared to triplet regimen, especially in both the volume of, both low volume and high volume. So the patient profiles has been discussed. So we'll move on to the next question. What are the challenges you face while choosing doublet and triplet regimens in Indian practice, Dr. Nitin?
Yeah, again, the first 2 points still stand. And see, there is a concept again with many of the doctors. Like, I've had recently one experience where I started off with, the patient was not willing for chemotherapy. So I started off with, I think enzalutamide and ADT. And the PSA dropped very fast. But in the end, I was questioned from a doctor, I think a urologist or somebody, like why it's a high volume disease, why wasn't docetaxel introduced? So eventually, we'll face all these things, lots of interferences from others. Still, there is a concept that high volume has to be treated with docetaxel. So that is one of the things. Like people are not exactly updated regarding, you can actually use ARPI if in a with ADT in a high volume disease also. That concept also has to be noted in many ways. But definitely, I think in the present age, I think when the guidelines very clearly indicate that you have to give the chemotherapy upfront along with there is a triplet regimen. So and the data also shows definitely we have to stick to that regarding regardless of what people think. So, a second thing is cost. Definitely, the low volume disease, again, Dara has got a cost issue, but otherwise, I think it's a wonderful drug. So, yeah, these are the fitness, the willingness to the chemotherapy. Lots of other small issues will definitely creep up whenever we take a decision. And another thing, which in the biological context, I think still we are standing, we have to explore a lot. There is actually, there are papers regarding SPOP, that's POP mutation, which responds very beautifully to ARPI. And there is a triple negative where I think they have analyzed the RB1, P10, and the P53, if I'm not wrong. And those actually you need to introduce docetaxel early. So given all these uncertainties, we do know that actually a lot of patients actually we are over treating. But still, I would want to stick to the triplet if the patients are actually fit, because in our centers, like they actually take multiple opinions, and we have to be sure that we give the best opinion upfront.
Yes, choosing a triplet option, definitely there will be an aversion in the society, especially when the patient is around 70 with cardiac issue, uncontrolled diabetes, and that we are using docetaxel, which can worsen the diabetes part. With the DEXA, we are using over there. But doublet, yes, we have to be very cautious, as Dr. Nitin was mentioning. Why wasn't the third drug introduced? Will be a common question from other people. So those two we do definitely practice. Any other challenges, Dr. Madhav sir, you have apart from these you have encountered?
See, the resistance again, depends on where you're practicing, the first point, right? Second is the cost. Third is also, I think it's kind of difficult to try and make them understand that, docetaxel, if you see, it's actually better tolerated in prostate CA patients, right? If you look at how docetaxel, when we're not actually too worried about docetaxel in prostate cancer, to be honest, right? That's always been what we've been taught from our medical oncology days. So it's not something that would keep you up at night, right? Although it does sound that you are offering chemotherapy to a slightly older gentleman. If he's fit, he has high volume disease, I wouldn't hesitate or wink, even a moment to introduce docetaxel. Right. So cost, again, resistance to giving chemotherapy, it all depends on how you frame it.
Yes. So yes, we'll move on to the next question, the last one. And a patient with non-metastatic CRPC on multiple cardiovascular drugs, will a lower drug-to-drug interaction burden will influence your ARI selection? So any one of you can take it. So what Bayer means is that darolutamide has less drug-to-drug interaction. Whenever a patient is having multiple cardiovascular drugs, definitely choose our drug. That is what they mean, I think.
Yeah, so that's one of their USP, like less drug interactions. Patients who are on polypharmacy, darolutamide does, is a good drug to give.
Yes, and it, as we have seen in both the trials, their side effects or the side effect profile will be similar to, the comparative arm, especially apart from that, some little fatigue.
I think there is a little bit of, transaminitis also, which is happening. I've heard many of our colleagues discontinuing because of transaminitis with darolutamide. But otherwise, I think it's a very fairly well tolerated drug.
Yeah. So that, I think we have reached the end of the session, and definitely I would like to thank Dr. Nitin and Dr. Madhav sir for making this session very interactive. And at the outset, I would like to thank Bayer for asking me to moderate this session. And over to the team. Thank you.
Thank you, sir. Nice presentation by Dr. Nitin sir and Dr. Madhav sir. And also thank you, Dr. Ramesh sir. Sir, before closing, let me check the chat box if any questions are there.
Yeah.
Yeah, I don't think so. Any questions from the audience, sir? So with this, we can conclude the session. Thank you so much, sir.
Yeah.
Thank you all.
Thank you so much, gentlemen.
Yeah.
Good night.
Thank you. Good night.
Good night, sir.
night.
Bye.